بسم الله الرحمن الرحيم. السلام عليكم. I am Professor Adam Ahmed Adam. This mycology lecture is a part 2 of the lecture Dermatophytosis. We continue the clinical types of dermatophytosis. Tinea manum or Tinea manus is the infection of the hand. The hand can be infected from the palm, the interdigital areas, and the dorsum. The commonest fungi, mainly Trichophyton rubrum, followed by Trichophyton mentagrophytes and Epidermophyton flocosum. Tinea pedis or athlete's foot. This is infection of the foot. You see here the upper picture in which the lesion is chronic, while acute in the lower pictures. The commonest fungi, the first one is Trichophyton rubrum, followed by Trichophyton mentagrophytes and Epidermophyton flocosum. There is a phenomenon known as two-foot, one-hand syndrome, in which Tinea pedis is associated with Tinea manus. It is found that many cases have got infection in the 2 feet, but infection in one hand. This is known as two-foot, one-hand syndrome. You see here, the 2 feet are infected and the left hand is infected while the right hand is healthy. This phenomenon is not yet scientifically explained. Dermatophytosis of the nails is known as tinniangium or onychomycosis. The commonest cause is Trichophyton rubrum. You see here, the nails become brittle and discolored, losing their smooth contour. At the end, they may be completely lost. Dermatophytid reaction. This is an allergic reaction to fungal antigens that appear as skin rash in non-infected areas. It is noticed that infection in one site may lead to allergic reaction in another site. Example, infection in the foot may lead to skin rashes in the chest, arms, or fingers. This is due to allergic reaction, which is hypersensitivity reaction. Diagnosis. By the diagnosis, we mean knowing the disease. The first step in diagnosis is the clinical assessment. Here, there will be history taking. You take history from the patient. You do physical examination. And part of the physical examination in such a situation is examination by the wood lamp. Wood lamp is a device that emits long wave ultraviolet light, and if such a light is cast on some of the dermatophyte infected areas, they may fluoresce, showing colors. Wood is a person who made this lamp? Who made this lamp? You see here the nail on your left hand side is fluorescing, and also the hair in the right hand side. Not all dermatophytes can lead to fluorescing, some of them. Then you go to laboratory investigations. You take the specimen, the thing to be examined. If this depends on the site infected. If the skin is infected, you do skin scraping. Scraping is by you scratch the infected area of the skin by a blunt blade or knife, taking care not to injure the skin, and then you collect the product of the scraping. If the hair is infected, you take the hair, nail, you take the nail clipping, and then you'd like to see that under the microscope. The fungus is deeply embedded in the keratin, and the keratin is radio opaque. It does not transmit the light. So you cannot in this way visualize or see the fungus. To see it, you have to remove the keratin to dissolve it out. How can you dissolve it? You add 20% potassium hydroxide. This is keratolytic agent. It dissolves the keratin, and now the light can pass through the specimen and you see the fungal hyphae and spores. You see here, this is the specimen after addition of the potassium hydroxide. You see here the branching hyphae, things like streams of water. These are the branching hyphae of the fungus. Then you can take part of the specimen and culture it in the Sabrot's medium. And the Sabrot medium is a fungal growth medium. It does not grow bacteria. Bacteria have different culture media. The growth, the fungus may grow taking a long time, 4 to 6 weeks to be detected. In clinical practice, clinical assessment, in addition to examination, microscopic examination by the KOH or potassium hydroxide preparation, may be quite enough for the doctor to prescribe or try the drug. The culture may be needed for epidemiology and scientific research. Treatment, topical antifungals are preferred. Topical means on the surface, the drug may be in form of creams, ointments, jelly, and be applied on the infected site. This is topical. So you can use clotrimazole, ketoconazole, terbinafine, and others. Sometimes you need to give systemic antifungals. Systemic means you take the drug by mouth, you swallow the drug, maybe in form of tablets, capsule, or syrup, so as to be distributed to all over the body, or injected. And that's it, and this is used in case of tinea angium. Tinea angium needs systemic antifungals, and also systemic antifungal can be used in topical treatment failure. If the topical drugs do not give the required result, you can go to systemic antifungals. There is a drug which is griseofulvin. This is in tablet forms. It is given orally by mouth. It is not classified in the antifungal drugs, but it is very effective against the dermatophytosis. It acts by binding to the newly growing keratin tissue, protecting the keratin from the newly growing keratin from infection, and the older keratin, when shed, it will be replaced by the healthy newly growing keratin. The treatment continues for some weeks according to the disease type. The aim of the treatment is to get rid of any fungus, not to leave any of it in the uh, skin. Prevention, how you can protect the people from infection. Number one, to treat the patients, these patients being human or animals. They constitute a source of infection. Um, and also to get rid of the source of infection as soil, you may treat soil, and fomites by destruction or disinfection, and then to reverse the predisposing factors such as worms and dampness. I hope that the lecture is understandable, and I wish you all the best.